Mode.
Good afternoon and welcome to today's Washington State Public Health Association webinar, the 2013 Legislative Report. Prior to starting the presentation, I'm just going to go over a couple of technical issues. You should all see a control panel on your screen. The control panel allows you to change the audio mode in which you're connected to the webinar. So if you experience feedback, please do switch from your computer to your telephone or vice versa. We will be taking questions at the end of today's webinar. To submit a question, just type your question into the questions log, and they will be monitored by me and posed to the presenters. And then finally, the webinar presentation and recording will be available later this week. And I will now turn it over to Jennifer Mum.
Hi, thank you all for being on the webinar today. This is a little bit of an unusual situation, as you all know, because when we normally schedule our quote-unquote end-of-session webinar, we are in fact finished with the legislative session. This year, obviously, the legislature is still in the middle of a special session. They've got just less than another week of this special session, and there's been a lot of speculation around Olympia as to whether or not they will need to go into a second special session to finish the budget work. That being said, the regular sessions, a lot of good policy did pass, or at least was advocated for if it didn't pass. And so we wanted to just go ahead and proceed with this today, and then know that WSPHA will put out some information after we finally have a budget. When this all ends, we'll send out some information about the final budget results. So today we're just going to kind of break up into two sections. The first on budget and funding priorities for the Public Health Association and our advocacy coalition, which is called the Public Health Roundtable. And then we'll talk about policy priorities and kind of go through what happened during session. And there is some resolution, thankfully, on the policy priority side. So we've got a great group of panelists, Brad Banks, who is with the Washington State Association of Local Public Health Officials. Most of you probably know it as WSALPHO. Sophia Aragon with the Washington State Nurses Association, Lucy Asdorian with the American Heart Association, Dick Coleman, who's with Uncommon Solutions and also heads up the Childhood Obesity Prevention Coalition, and Blake Trask with the Bicycle Alliance of Washington. So these are fabulous partners that we work with all the time in Olympia and beyond, and we really appreciate them being available to give some updates today. So Betsy, let's go ahead into the first section. So Brad's going to kick us off talking about where we are with core public health funding.
So hi, good afternoon, everyone. I hope everybody can hear me just fine. I'm traveling, so I apologize if the connection is bad. From a local governmental public health perspective, we had an interesting session, or at least regular session, and now continuing into the special session, with regards to how local state dollars in particular will flow to local public health jurisdictions across the state. The good news from our perspective is that both budgets preserved at the current levels of funding that we saw in 2012, 2013, going forward for 2014, 2015. So we started out very, very nicely, at least in both budgets. The difference was primarily the approach. The House budget went through sort of the traditional approach that basically has there are three central pots of money, and I know for many of you probably know this, but there are sort of three central pots of money that come to local health jurisdictions that are sort of quote-unquote flexible dollars. And those are for kind of doing the basic foundational work that public health, governmental public health does. And so those are the MVET backfill dollars, the 5930 dollars, and the local community development fund or LCDF dollars. So in the House version of the budget, all three of those funds continue to come to us in the same manner as they have in the past, which is traveling through the Department of Health, and then from the Department of Health are then allocated out to the separate jurisdictions. The Senate took a different approach, what's being sort of referred to, although not technically correct, as a block granting approach, which is combining the three fund sources into a single allotment for each jurisdiction, and then having those dollars sent directly to local health jurisdictions by way of the state treasurer's office, and therefore bypassing the Department of Health. And in the process, the Senate did take back certain overhead dollars and some programmatic dollars that traditionally have helped fund work at the state level, and so there was a reduction there. So we were kind of left with two different approaches and where we were going to land. And I think where we as WSALPHO and our close affiliate, the Association of Counties, have decided to land is we actually prefer the Senate approach of the direct allocation. We prefer it for a couple reasons. One, it provides probably the maximum amount of flexibility for those dollars to come to local health jurisdictions, which at this point in time, with all of the federal things we have going on, as well as federal reductions and other things we are nervous about, assumptions as a result of Affordable Care Act, et cetera, having that maximum flexibility is really important to us. So we like that idea. Secondly, it keeps these dollars consistent with how other dollars that come to local governments flow, meaning this approach of having the money sent to the county or to the state treasurer's office and then just having them dispersed out to the different jurisdictions. So there's a consistency issue from that perspective. So we prefer that approach. However, we certainly are not supportive and don't like the idea of the Department of Health having to kind of bear some pain as a result of that. And so we have been working to try to find a hybrid solution where we can continue the Senate idea of this direct distribution of funds while at the same time preserving any dollars that might have been lost for the Department of Health that was kind of found in that original Senate proposal. So that's where we're at now. There has not been a lot of conversation or discussion about which way or another things are going to go. I think where we feel comfortable is at this point we feel like our core foundational funding is safe. It's just really an issue right now of how it actually ends up getting to us. So that's kind of where we're at from a budget standpoint from our main core dollars. Obviously, there are other programs we're very supportive of. The Tobacco Quit Line, which travels to the department, is something that the Department of Health works on. It's something that, as tobacco dollars and other things have heavily reduced around the state, that's one of those few areas where there's still work going on, and so we're supportive of that. One budget was, the House budget was kind to that. The Senate budget wasn't. So we obviously prefer the House budget or House version there. But beyond that, I won't go into too many more details funding-wise. Any questions, thoughts? Something I missed, Jennifer?
I think you did great from my perspective.
Okay.
Okay. So just to cover some of the safety net programs, and again, obviously we're basing this on the House and Senate versions of the budget that passed during the regular session. Maternity support services, to the extent that any program can be safe during budget time, has been fairly safe this year. We haven't had to do a lot of advocacy around it. There's been no intent to really change it from its 2011-13 biennial funding amount. So I did put it up there just because kind of in the fray of the last couple weeks, there's been some rumors that now all bets are off and everything's back on the table. So there's a bit of advocacy starting to happen around that now, but hopefully we'll see it maintained at current levels going forward. The adult dental program was treated quite differently, as you can see in the Senate version versus the House. The Senate funded about $30 million, and the House budget fully restored adult dental at about $73 million. And so what the difference is kind of in the Senate budget is how it's been described is what this additional money would pay for would be for more people to be able to go in and see a dentist, for example, to be diagnosed with a cavity, but then there's not enough money there to pay for people to actually have their cavity filled. So the House budget is very much preferred, and I think that's one that we're watching very closely. Apple Health for kids, the premium assistance for families is in there in both budgets, which was a great win going forward, and hopefully we'll continue to see that in the final budget. Take Charge family planning waiver has been a bit of an issue. It's been included in these different programs, as a lot of you know, with breast and cervical health program and HIV/AIDS. With the Medicaid expansion, looking at what portion of those programs might be able to be reduced or eliminated as we move into 2014 with newly covered people in our state. So for Take Charge, for example, the Senate did include a bit more funding than the House, and I think we'll just kind of see how that rolls out. Our understanding is, at least during the regular session, programs like HIV/AIDS did have the DOH, Department of Health component around prevention was maintained. And I know that Lucy and Vic will probably touch on this in their section as well. But the other one thing I really wanted to point to is funding for the tobacco quit line. There was no funding provided in the Senate budget. The House provided $3.9 million in funding. And in what was a really great win as well for the broader tobacco coalition is that they actually changed the line item name from the quit line to actually be a placeholder for a tobacco program. So Lucy, feel free to jump in if you want to say more about that.
No, Jen, I'd just add that while we were here on the phone, the House has released another version of its budget, so I haven't had a chance to really dive in at all, but it literally just came out.
Excellent. So everything that we just told you may be moot at this point.
Yeah.
we were laughing about this just before the call started because there is a press conference probably right now in Olympia where we had all been talking about rumors about a new version of the budget coming out. So once we've had a chance to take a look at that, we can get some more information out to folks. So I will stop there. Betsy, if you want to go ahead and go to the next slide.
Hi, this is Blake Trask at the Bicycle Alliance of Washington. I'm wondering if you could actually go to the next slide. So one of the items that has passed is the transportation budget, even though we have operating capital and potential transportation revenue still on the table in the special session. The transportation budget was relatively drama-free in that both sides didn't look to really add too much revenue or didn't look to really change much from the previous biennium. That being said, I think we can recognize that we had some significant wins around the Safe Routes to School grant program budget within the transportation budget that passed between the House and Senate. Due to a lot of issues with the way federal transportation has changed its funding over the last year, there were a lot of debates and conversations as to how Safe Routes to School would be funded, and this really started last summer. And since then, the House and Senate had some real significant conversations as to how they would allocate federal funding for Safe Routes to School. And we had some really great champions namely Senator Andy Billig from Spokane, who really works with his Senate colleagues, and on the House side, Representative Jessamine Farrell and others on the House worked with her colleagues to propose an amendment to add additional federal funding for the Safe Routes to School funding, which would have essentially flatlined by the 11-13 biennium to the 13-15 biennium. The result being is that we got an additional $4.5 million in biennial funding for the Safe Routes to School program. Something that may or may not still be up in the air is revenue for based on a revenue exemption from an outdated 1937 gas gambling loss tax break, which would be an additional $5.2 million for the Safe Routes to School program. So the end result is right now we're looking at instead of having a $14 million biennial budget, we might be up to 18. We will be up to 18.5 million, and we might even get up to $24 million for the next 2 years to deploy Safe Routes to School programs across the state. The other element of bicycle pedestrian safety and mobility program will remain at $12 million for the next biennium, which is exactly what Governor Gregoire proposed in her original transportation budget for this biennium. I think I said the overall budget is more of the same. We still have a lot of work to do to grow active transportation in the overall transportation budget, but still these two represent significant wins. The other thing that's in play, as Lucy mentioned, the operating budget is moving. This is a really unique year in that in past years when there were big transportation budgets out there, they operated relatively independently of the operating budget. This year, it's seen as being very very dependent on how the operating budget goes. So if there's minimal revenue on the operating budget side, there might be a higher chance that the House and Senate can agree on proposing a transportation revenue package. The current package proposed on the House side is about $8.4 billion. And in active transportation, we've done a pretty good job of negotiating up to getting about $370 million included in that $8.4 billion package for things like complete streets, for more safe routes to school, and for investments in walking and biking safety and mobility. We'll be really watching over the next 5 days to see if the Republicans propose kind of a counteroffer to the House proposal, and we'll be going from there. But it's really, I think, dependent on what happens in the operating budget. If we see a lot of revenue in the operating budget, I think it's going to be a harder push for us to really see a transportation revenue package gain legs moving forward. That being said, the Governor Inslee has really staked his position as transportation revenue being a jobs package and something that's really central for a win for him in this year. That's it.
Thank you, Blake. That was great. And we are going to move into the policy priorities section.
Okay. Good afternoon, everybody. I'm Sophia Aragon from the Washington State Nurses Association, and to give you a status report on what's happening with health reform implementation. But I wanted just to add a little bit more information in terms of what you've already heard regarding the budget, because what's happening with health reform obviously is really contingent on what happens in the budget. So just a friendly reminder that when we started session, we had a $1.3 billion revenue gap, and in addition to that, we have a $1 billion liability for K-12 education. And we've seen revenue packages raising as high as $600 additional million from the House. And as Lucy and mentioned, that a new package was just released at 12 noon in a press conference. And I'll just share a rumor, so that's a big disclaimer about what I'll say in terms of statuses and what's going on, is that we'll see a significantly lower revenue package from what we've seen at the beginning. There's been a lot of slowdowns politically. I think many of you know that, unfortunately, Senator Carroll passed away in the 28th District in Tacoma. And so the 24-24 vote tie has really slowed things down in the Senate. But Representative Oban has been appointed to that seat yesterday by the Pierce County Council. So it looks like they'll be more willing to return to business quite soon. The other thing folks should know is that the regular session ends June 11th. It's very likely that we'll go into a second special session, given that the House looks like it's changing its tactics today. We don't know the details of that, as said before. And also to keep in mind is that June 15th is an important date in terms of what state agencies need to know what's in the budget in order to carry on some administrative business. So just wanted to give you a little bit about the dynamics out there to date. And Jen gave you a really good picture of Health and Human Services funding, but I want to emphasize that that's all in the air because today we do not have an agreement on either the funding levels in the operating budget or revenue level. So that's all, again, sort of guesstimates and speculations. So I'm going to start with the health benefit exchange. House Bill 1947 sets up the funding mechanism for the exchange, and it's been called the hybrid model for the reason that it's a combination of existing premium taxes that health carriers already pay, and it's to be diverted into a special account to support the exchange. And also the exchange may raise assessments or additional fees on carriers if they fall short of what the legislature estimates is needed for operations of the exchange. In terms of where it is, it's reverted back to the last version in the House. And the main controversy there is some language about the board's ability to influence qualified health plans and criteria. There is some controversy about what is the legal ability of the board to even make such changes, but it's easy to assume that they do have some authority to further develop the criteria of health plans that are offered. And on the carrier side, there is concern that there may be changes that isn't appropriate for the board to make, and therefore the legislature should make those changes. And many consumer advocates, on the other hand, would like to see the board talk more about what additional criteria we should have on these plans to advance quality. And for any of you who are following exchange board meetings, the policy committee had a report of a very robust discussion they had during a retreat about all of the tools that they've been educated by through the provider community of how do we improve care. So there's this hope on the consumer side that the board will have more robust discussions, and the exchange could be used as a tool to advance better quality health plans. In terms of budget, the House is closest to the estimated need of $50 million to run the exchange as it takes off. The Senate was much lower, but technically it's because we only have a House bill out there that has a proposal for funding. The Senate did not have a proposal, so there's more of a complete proposal. I would like to characterize it on the House side. In terms of Medicaid expansion, we began session with it being most likely a budget exercise. And there was a lot of work during the interim to get the legislators on board and in support. I think the general notion is that there will be some form of Medicaid expansion implemented in the states. But right now there is a bit of a gap in terms of the assumptions of savings in the Medicaid expansion, anywhere from $200 to $300 million between the two chambers, and the bulk of that is an assumption of some folks going into SSI who are eligible and have disabilities. So the other thing that's in play is that in the Senate they did introduce a bill on Medicaid expansion, Senate Bill 5894. There has not been hearings on it, but it does give you a good glimpse of what the Senate would like to see in terms of some limitations in Medicaid expansion. For example, there's an interesting circuit breaker approach where it's to protect the state if the federal government cuts support for programs below 90%, which is what is expected in year 3 of Medicaid expansion. There are some cost-sharing provisions which are concerning to many advocates because we're already talking about a low-income population that that will be a barrier to them accessing this program if we impose cost-sharing. But there are some incentives to emphasize wellness and preventative care. However, there's not much detail about how that would work out. So that is the status for both of the two major parts of health reform implementation, Medicaid expansion and the exchange, and both of them are very intimately related to the budget.
Thank you, Sophia. Vic and Sophia, I think you're up.
Okay. Hi, sorry, maybe my connection isn't going very well. I'm having a little bit of a hard time hearing you.
Sophia, can you mute? I think that might be the issue.
Okay, I think I'm just going to go for it. I think we can go to the next slide. All right, so first I just wanted to talk a little bit about some bills in the tobacco prevention area. The first one, and this first slide, I just want to, it's kind of a reminder of the cigar license bills we saw over the last few years. And what these would do is create a loophole in Initiative 901, our Clean Indoor Air Law, to allow for cigar lounges and tobacco stores to essentially purchase a license to allow smoking back inside. It wouldn't allow for cigarette smoking, but was not specific on other types of smoke. And it would allow for a cap on the number of lounges, but that cap was pretty high. It was 100 lounges and 500 stores. So we're talking about smoking back in 600 places. And within those licenses, there were some requirements around just what a lounge or store would have to do to comply and to keep smoke out of other places and other parts of their stores. The lounges, it was as most would say, it was maybe impossible without designing it pre-construction, because you wouldn't have been allowed to, have any smoke seep out of that specific cigar lounge. For the stores, it was a lot more flexible. So that was where a lot of the concern was for communities and for just constituents, because you can just picture some of those cigar stores in, next to our drugstores, next to dentist's office, next to all sorts of things in those strip malls. And there would really be no requirements around making sure that there wasn't shared ventilation or smoke going through, the ceilings or the floors or the walls or anything like that. So in 2011 and 2012, we had a pretty hard fight to kill these bills. In both years, they were tied to the revenue for the license was tied to tobacco prevention funding, and so it was a tough call to have to fight that off and lose the ability to get funding for a tobacco prevention program. And in both years, we really defeated it in the final hours of session. It really came down to the wire. So you can go to the next slide. But in 2013, the bills were back again. We had a hearing in the House side that went, about like they have for the last few years. There is certainly a contingent on the side who supports these bills that cigars are for adults, they're fun, they're not dangerous, and we really had to bring out the public health message in full, in full effect of this is very dangerous. This is not a direction you want to go down. The bill didn't move out of committees. It hadn't gone anywhere. And when the Senate was working on their budget on the floor, it was pulled up as an amendment, and it failed on a voice vote on the floor. So that was probably the most exciting moment we've had in the 3 years of fighting this bill, because we've never actually had it go down in a vote. So, I say that, I guess I will temper my excitement a bit just to say that I believe these can come back any time as they have been ruled necessary to implement the budget in previous years. You know, I really want to believe we'll get a little tobacco prevention funding this year and not be tied to these bills, but it's not over until it's over. You can go ahead and go to the next slide. So the other bill that was a big priority for the Heart Association, and we were very thankful to have a close collaboration with the public health, our partners in public health, was House Bill 1556, and this was around CPR training in high schools. And this is an effort we started last year, and through working with both our partners on the public health side as well as on the school side, we really heard loud and clear that adding a new graduation requirement was not the way to go about training every kid in our state in CPR, and that students are already taking health class, and if we incorporated this as a part of health class, that would be much more manageable for schools. It would be much more manageable for community partners, and so that's how we moved forward. And it was an extremely tough fight, but we had great bipartisan support in the on our House bill, and we're able to get that passed and signed by the governor on May 8th. So we're really excited to start working with schools and work with local EMS and public health on how we can implement this. I think one of the important things to know about this bill is that it's not a certification in CPR. It's just kind of learning those basics of how to do hands-on CPR, how to use an AED if it's available, and really shouldn't take more than a class period, if even a whole class period, because there are just so many new ways out there to train CPR more effectively and quicker. So we're really excited about this new opportunity and to see kids in every corner of our state get trained in CPR. I think that's it for me.
Hello, this is Nick Coleman. Good afternoon, everyone. I'm going to share with you a couple other bills that have been in play. I'm going to get some help from Blake Trask in a moment on one of the bills. Let's start here, House Bill 1321. This is the bill that's been in one form and another for 3 years now, and has been a very successful strategy both locally and nationally, which is all about getting government agencies to walk their own talk when they are providing food, whether that's food to employees, food to visitors, food to folks they take care of in custody. So we've been working this bill pretty hard now for 3 years in a row. We got movement on this bill again this year, but more importantly, we got, I think, greater progress and buy-in by state agencies. State Department of Health has grabbed us a little bit harder as well in the last year or so. And we are now seeing a place where agencies like Department for Services of the Blind, I think, are seeing that the sky will not fall if we do have some minimum standards around healthy food, i.e. in vending machines and in concessions and cafeterias. So where we are at this point is we are getting some interest from the governor's office on this issue, and there is some negotiations going on that I think will get going more in earnest after the session is over about a potential executive order that might grab this idea. So that is not at all a done deal, but definitely reflects interest on the part of the governor, who talks a lot about childhood obesity prevention. And although the connection here to the childhood part of this is a little attenuated, we do have places like our juvenile justice facilities that would have to have compliance with this issue area. So to be determined still, but clearly we see this as a strong effort that from a legislative perspective has putting good pressure on this issue. And again, I think from a local level, we love to pick ideas that also have a local flavor to them. I know that there's a number of jurisdictions that are working with cities and counties, and even our institutional friends out there, places like zoos and other community gathering places, that also might be teed up to do this kind of work, to develop some healthier food and beverage standards. So again, we'll see where this one goes. We'll clearly bring it back if we hit the walls here with the governor, but we're feeling hopeful about where this can go from here. We're going to go to the next slide, and Blake, why don't you start? I'll mute and take it from here.
Great, thanks, Vic. The Neighborhood Safe Streets Bill, I think a number of you have already heard a little bit about this, but this is legislation that provides cities and towns the authority to lower speeds on non-arterial neighborhood streets to 20 miles per hour without having to conduct a costly traffic and engineering study. It was, I think, a pretty tough battle, but one of the things that was really, really valuable was our support from a number of different corners of the state, and most importantly, I think, from the public health and public safety community. Getting your calls and support into key legislators was really valuable. We also got strong support from organizations like AARP, Children's Alliance, AAA, and others, as well as cities and towns, and that really made the difference because this is legislation that most legislators were pretty familiar with. It passed out with strong local support, strong bipartisan support from both the House and Senate, but just sort of languished when it finally got to the Senate floor with probably 2 weeks before cutoff. And it was your help and, I think, pressure that got us to make the legislation the very last bill that passed out of the Senate this year. And it was pretty exciting, a little stressful to be the 459 bill. But that strong support from lobbyists and from individuals alike really made the difference. We're really excited about next steps because we really feel like legislation is only as good as how well we can implement it, and I'll pass the mic over to Vic to talk a little bit more about that.
So just a PS on that, thanks, Blake, is that this is a terrific example of a bill that is looked at a state level, but is really about supporting local work. So all this bill does is give authority to locals to lower speed limits. It's now on locals to pick up the torch here and do that work. So for many folks who do healthy communities work at local levels, I think this is one of those low-hanging fruit ideas that would be a perfect local policy effort to get into. It could be, I don't know if it's an easy win, but it's certainly an understandable win. And because it did have bipartisan support, I think it could maintain that flavor at the local level. So we'll do some encouraging as well with our context at the local level about, hey, here's a great opportunity to take on this work at a local level and slow down the streets near sensitive land uses. So we're pretty enthused about where we see this bill can go. Again, as Blake just said, enactment is part one, implementation is part two. All right, why don't we go to the next slide? So House Bill 1233, we saw this bill pop last year. Then Representative Billig introduced it, and we had some pretty healthy debates on this issue area and got it all the way into the Senate side. This year, this bill didn't quite get the time and attention that it deserves. So we're hopeful to see this bill pick up again next session and hopefully have a little more attention and bandwidth for all the groups behind it as well as the sponsors. Just FYI, there is that challenge on this bill, which is sort of under that very broad conceptual umbrella of health in all policies, that for some people this bill makes sense. We're just adding a health lens in the transportation world, and why wouldn't we do that? For others, this looks just like an opening for big government, and for some legislators, they've heard of these health impact assessments, these HIAs, and for some of them, that is scary because that sounds like it's super expensive, costly, overly bureaucratic, etc. So there's some, slaloming we have to do, some messaging we have to do around this bill in the future. On the other hand, we have a brand new person now in charge of the Washington State Department of Transportation who is clearly an active transportation advocate. And although she's not going to change the world overnight, This concept could be something that she'll be grabbing as a matter of course within agency work, but she might need that legislative support as well. So I do see this bill getting reintroduced and getting pushed again in the future. Okay, one more bill to talk about from our next slide would be a new bill that we pushed this year on child care and standards in child care relating to nutrition, physical activity, and screen time. We've had kind of a mixed bag with this work in the last couple of years, mostly through the rulemaking by our Department of Early Learning. They have done some major rule rewriting for 2 of the 3 legs of the child care world, at-home providers and school-based providers, before and after-school providers. We are still waiting on that 3rd leg of rulemaking to happen, which is the more professional, or what they call center-based rules. So DEL has done good work in changing those rules for the school provider world for physical activity and screen time, not so much on nutrition. So we took this issue to the legislature and definitely got the interest of many folks who were quite intrigued to hear more about this. And we do have the solid champion here, Representative Farrell of the 46th District, who really, as a young parent, is very interested in this work. So we wrote a bill and ended up not having a hearing on the bill, but it had a full 2-hour work session on the issue area in mid-March in the Early Learning Committee, and that really was a terrific opportunity to open eyes and really hear from a number of different folks around this issue area. There's a number of pushes on this work in other states. The Michelle Obama work, Let's Move, has underscored the work in child care. So this is clearly an emergent issue, and there will be chatter over the summer about where we go from here. So we've basically just opened up the door to this work, and we've already seen, frankly, some much stronger partnership work on the part of Department of Early Learning in a number of different settings. So I think message received from that department, and when they engage in any future rulemaking, especially for the professional-based child care folks that could come as early as this year, we think we're well poised to see some shifts in how those rules get written. And just so not everybody's completely scared, the bacon baby is actually not a real product, although I bet some of us wouldn't be surprised if it was. Okay.
Thank you for clarifying that, Dick.
You're welcome. So you've already heard about budget. You can see where we're prognosticating. We have no idea where so much of this is going. We're tracking a number of different budget issues, especially in transportation. But on food and nutrition, there's a number of pieces that are in play, and there's going to be a lot of work and turmoil here in these next few weeks, we're sure. So I think just a couple quick reflective comments. For us as Childhood Obesity Prevention Coalition, we did have a lobbyist presence this time, Aaron Jajek, and hearing so much from Aaron and our close partners like Lucy at the Heart Association, I feel like there's a little more optimistic play for Healthy Communities work state level, and some of the work we've been wanting to do over the last few years actually does have a budget cost to them, and the bad economy has suppressed many advocacy efforts over these last few years. But just as a conceptual idea about the obesity epidemic and what do we do about it, I feel like we're poised to deepen our work and really create even more success in the future. So we're still pretty excited by that. Our active transportation partners continue to be real successful in getting some of the pieces done. We feel great about the partnership between health and active transportation. That seems like a good 1-2 punch that's been working in some arenas. And as you all know, the last comment I'll make is we constantly are fighting the rearguard battles to hold on to the little shreds of money that we're getting out of the Affordable Care Act into that prevention fund, and I think we all get unbelievable action alerts to save the fund ever since it was created. So I would just say we need to continue to do that. That has been the first piece of legitimized community-based prevention money we've seen in public health, and to lose that would be a real huge loss, not just the dollars alone, but sort of that legitimacy factor there. So we continue to push those alerts along and encourage everybody else in the field to answer the call on those. So I think that wraps up my piece. Thank you.
This is Blake, and I think actually a lot of what I cover, what Vic covered, is what I was going to be talking about. The only other element that I think I will just highlight, because we talked about the public health, our health as a transportation policy system goal already, is another thing that we were pushing for and we're still very interested in is expanding things like safe routes to school and walking and biking to school through the lens of McCleary. And one of the elements we were looking at was a potential budget proviso that didn't make it through the budget this year, but we'll be revisiting in the future, is to develop some sort of pilot project or action project with a couple of pilot school districts to start exploring how do they start to move away from the continued costs of school busing, and how do they focus much more on getting kids to walk and bike to school? How do they focus more on developing active communities to reduce the pretty high student transportation costs that exist in the state right now? I think on an annual basis, the state and local school districts are spending about $450 million on Yale school buses. So we're really interested in playing a little bit more in the McCleary game moving forward, especially as what it looks like with the operating budget proposal by the House Bs today, is that they're putting a down payment on McCleary. They're not fully addressing the issue of McCleary, so we'll probably have more conversations in the upcoming session and in the next biennial on McCleary. That's all for me.
Thank you, Blake. Brad and Sophia, if you guys want to cover House Bill 1538, that would be appreciated.
Sure, I'm happy to. Sophia, I don't know if we can tag team it, I guess. So we had House Bill 1538, which dealt with public health nurses dispensing certain medications for communicable disease and family planning. And this bill is really the culmination of a lot of work that had been going on between the Department of Health, local health, nurses, a variety of other groups to deal with a situation that we have with local governmental public health, where a lot of our public health nurses are in situations, and not just in rural areas, but in a lot of areas, to dispense medications under the orders, standing orders of a physician, the health officer, for a variety of things. And oftentimes, this nurse will be required to go out into the field and dispense certain medications, particularly in the communicable disease situation, sort of in a prophylactic way. So you come in with meningitis, you say, oh, I'm here and I've got this issue, and I went to lunch with 6 people today, and then I went to the movies, and this, et cetera, et cetera. And so, the public health response is then to go back out and figure out where there was possible exposure, who could have been exposed, and then try to treat them right out of the gate to try to prevent as much and contain as much potential spread as possible. So at any rate, that's kind of the big example from a communicable disease standpoint, and how that might work. And so it's the public health nurses really on the front line doing that. And the issue kind of arises when, in those scenarios, that individual may not necessarily, or an individual that the public health nurse sees in the field, may not necessarily interact directly with the health officer or a doctor. And so there's this sort of go-between. And this is kind of a practice that's already happening. But we feel there are some scope issues and some potential liability issues that we would like to have this practice sort of affirmed in law as a very unique governmental function, public health function. So from a communicable disease standpoint, that's the one side of it. From a family planning standpoint, obviously, I think we can all see where that fits in. Health departments are oftentimes the place where, particularly those in underserved areas or low-income areas, come to get family planning meds or et cetera, et cetera. So again, it was kind of the same scenario where they may not necessarily have interaction with the doctor, but the nurses are certainly filling that role just fine. And so we want to try to, and quite frankly, just because of the result of funding restrictions and staffing, and where many health departments are these days, we just don't have the ability to have multiple doctors, hundreds of nurses. The need is really to be able to use our money as efficiently and as effectively as possible to achieve these goals. So we put this bill in place, sponsored in the House. Got this bill through the House. I think the final vote in the House before it passed over the Senate was like 75 to 22 or something like that. Came over to the Senate, passed out of the Senate Health Care Committee without a single no vote. Actually, also in the House Committee, it was a unanimous vote, and then stalled. And it stalled really in that last week of the regular session. And the result of the stall, there were a couple things. One, there was some confusion or some concern that occurred those last couple days during the session around maneuvers that were happening in the Senate around the Reproductive Parity Act, and that this bill potentially, our bill 1538, could be seen as a vehicle for some of that maneuvering. So that was one of kind of the first hurdle. The second hurdle that really started to come up, and it had always sort of been boiling below the surface, was a concern in the more conservative caucuses around the Plan B component of family planning. And obviously, family planning by itself is generally pretty widely supported on both the D and the R side, but the Plan B component of it was particularly troublesome to certain legislators. So it became an issue in the Senate where I think, in all honesty, there was a desire to not have the Senate Majority Coalition Caucus split over this bill. And so it ended up not being brought up for consideration and thus didn't get out prior to the final day of cutoff. So it reverted back to the House of Representatives where it's sitting. Now, we have been pretty aggressively working to try to make this a bill that gets reconsidered during the special session. Now, that's a long shot to begin with because it's not a budget bill or a transportation bill, but we do believe it's a sound policy bill, and it was the primary policy ask from governmental public health this session. And we, along with the Medical Association, the Nurses Association, pharmacists, WSALPHO, Local 17, there have been a number of groups working really hard to try to get this bill brought back up. And I think the real reasoning and the real feeling was we had all the votes we needed to get it passed in the Senate. And that was, I think, the most painful part was, had this just gone up for an up and down vote, it would have passed out of the Senate probably by a pretty good margin. But because of a variety of, I don't know what you want to put it, just sort of the politics and personal politics of a variety of scenarios, and from an image standpoint, they were concerned about looking like they were somewhat divided on a particular bill. So we're hoping that we've had some very good conversations, both with some senators as well as back in the House, to try to see if we can bring this bill back to life. I think we're still, it still remains to be seen if that's going to be possible, and I don't know if we're going to be able to, with the way the politics are working in the Senate, if something like this Plan B component of that is something they're going to be able to get over with respect to getting a bill out that might have some a number of senators voting no in their caucus, which they've tried to avoid all session. And we knew going in that they were only going to try to pass out bills that they were pretty much all supporting across the board. And so this is a difficult one where they could see some fracturing in their own caucus, and they've been really hesitant to pass bills out that might do that. So that's kind of where we're at. And Sophia, I don't know if you want to add to that at all, but we're very hopeful that we can edit something this special session. But if we can't,
thanks, Brad. I think we
okay. And so,
Go ahead.
so for example, we'll keep up this for 2014.
And Brad, I just want to add that when regular session ended, there was very little talk about what the session was limited to, the special session. So I think there was a lot of positive energy around bills like this one that made it really close. But from more informal announcements from the governor and other folks, it's really coming down to the budget, and unfortunately this bill is getting lost in that.
Thank you both, Brad and Sophia, for going through that bill. And Sophia, can you mute again? Thank you. I think that's the feedback. Really quickly, I see that there's some questions, and I know Betsy is going to go through those for us to make sure that we get to all your questions. But having just briefly had a chance to actually take a quick peek at the House budget that was released while we've been on this call, there's just a couple pieces that I can follow up on from the earlier piece that we talked about. So the new House budget that was released today has about $789 million less in spending than the previous House budget. But on the sort of public health budget items that we've already talked about, this version of the House budget does block grant the 3 public health funds. So Brad talked about that earlier. It does actually looks like it implements the Senate version of core public health funding. It looks like maternity support services is maintained in this budget. Adult dental looks exactly the same as the previous House budget, funded at $73 million. The Apple Health premium assistance is included in this version. So obviously there'll be more analysis done as those of us on this call and others have a chance to kind of dig into it a little bit more, but I just thought I'd mention those quick highlights before we go into questions.
Okay, so if you do have questions, please submit them now, and we can post them to the presenters who are best suited to answer them. In the meantime, the one that has come in is where does the budget, the governor's office stand on the budget? If anyone could talk a little bit more about that.
So this is Jennifer, and so Governor Inslee, I'm assuming that's the governor's budget, that is the governor's budget in play now, so I'm assuming that was what the question's referring to. Governor Inslee did come out with a budget proposal during the regular session. You know, it had some key priorities. It has sort of been, there's been some discussions back and forth at a general level between the House, Senate, and the governor's office. I've heard that there's some key sticking points. I can't speak to what those are. And I'm just going through my list here to see. A lot of our stuff actually wasn't covered. A lot of the public health line items were not covered in Governor Inslee's budget because he tended to focus on some of the bigger pieces, but did include things like the Medicaid expansion. So anybody who wants to say more of our presenters should feel free.
This is Sophia. In general, the governor was aligned really well with the House approach, and I haven't heard anything to the contrary. So I think that's the big takeaway in terms of a comparison between the governor and the House versus the Senate.
Okay, we have not had any other questions come in at this point. So thank you for joining us today for the webinar. Our next webinar will be on July 17th, and it will be Solving the Looming Crisis Leadership and Management Succession Planning, featuring Secretary of Health John Weissman. And announcements about that webinar will be going out in the next week or so.